Welcome, everybody. Another night on Cosi Talks, and we are here. Homework is done, dinner is done, kids are bathed and ready for bed. Good day, good day. It's always a victory in our household. All right, guys, I'm going to wait a couple minutes for y'all to jump on board. And if you are watching the replay, please put replay into the comment section. That way I can look back and see who was watching the replay and also if they had any questions that I will answer after the show's over. So once again, if you're watching the replay, go ahead and throw that into the comment section for me. All right, I see some people jumping on board this evening, guys. Don't be shy. Let me know who you are, where you're from, and what's in your glass. Today it's pretty boring for me. It's just water. It is still very hot and humid here in Florida. And we actually have a question tonight regarding how much water you should be drinking. So we'll be addressing that one a little bit later on this evening. All right, guys, see you coming on board. Don't be shy. Who have I got this evening? We got Joe Green. Howdy, listening in from my YouTube channel. And yes, guys, I am streaming also to my YouTube channel, also under the name Cosi Talks. So for those of you who are not big fans of using Facebook or that platform for watching live shows, you can watch me on YouTube as well. Hey, Angela, watching me from Roan Mountain, Tennessee. We got Daniel Waters from Southern Indiana. Hey, Susan, another person watching me on the YouTube channel. Loving it. Thanks, guys. All right. Hey, Jeffrey, what's going on, man? Jeffrey, another YouTuber. Awesome. I love it. And Barbara, we got Barbara on board. Oh, hey, Barbara. We got Glenda from Seattle, Pam from Indiana. We got Devin. What's going on? Guys, good to see you guys. Good. A lot of good people here tonight. I'm expecting a couple of new folks here tonight, so it'll be fun. We've got Bonnie watching from Knoxville, Tennessee. Jeffrey, I've got your question here, so buddy, stick around. What's up, comadre? All right. Is it chilly over there? Yeah, so not chilly over here. So not chilly. In fact, I want to turn off these lights because it's cooking in here. Johnny V from Poughkeepsie, New York in the Cosi Talks house. What's going on, man? Hey, Van Gregory. Ooh, Van Gregory brought the really cool emojis and like the, oh, what are those things called? The pictures of yourself on there. That's awesome. Hey, Kathy from Washington. All right. We got Cindy here from South Carolina. Hey, Van Gregory, you're getting fancy on me. Marianne from South Dakota. Marianne, I've got a lot of your questions here this evening that we're going to be talking about. Lots of topics tonight, Pam, lots. And that's why I'm smiling, because I love it when you guys send me all these questions. When I open up my inbox in the morning and I see question, I'm like, yes. So I've got lots of questions from the viewers tonight, lots of really good questions, and a couple of new questions. So I'm excited about that. Lots of stuff, Pam. So Daniel says, that's why I'm getting ready to head out the door to Florida. Okay, Daniel, you might want to hold off another month or two, and that's when the nicer weather around here starts. That's when we start getting all of our snowbirds here. All right, guys, another couple of seconds, and then we'll go ahead and get started. I know we have some new folks here tonight. So guys, if you're new, don't be shy. I love it when people interact on the show and put their questions and comments in the section. So feel free. All right, guys. So to officially introduce myself, my name is Cosi Velloso. I'm a physical therapist, amputee specialist here in hot, sunny, sticky Florida, Tampa, Florida, to be more precise. I've been a PT now for a little over 18 years, and I have a clinic here in Tampa called Palanca that is exclusively for working with the limb loss community. So very excited about that. All right. Hey, Matthew, what's going on, man? You got the Corona light? Oh, that sounds really good right about now. Sounds really good. Susan says it's getting cold over there. Yeah. All right. You're leaving in 4 hours? All right, Daniel, then I better get cracking. So we had a lot of questions, and some of them were rollover questions from what we talked about last week, guys. So last week we talked a little bit about K levels and functional level testing. So just as a brief overview, okay? Years ago, and I think we're approaching 30 years now or something crazy like that, Medicare invented the K level system, right? And it was basically a system to kind of categorize amputees according to their mobility, right? And depending on what level you were assigned, or you are assigned, it's still being used, will determine what kind of prosthetic devices you have. So you have K0, K1, K2, K3, and K4. Okay, so the K0 is basically the person who has very low mobility, that basically using a prosthesis will not help them at all with their mobility or enhance their quality of life. K4 on the opposite side of that spectrum is your hotshot athlete, right? These are the folks that are candidates for running, that they have running blades and higher technology for sports related type prosthetic devices. So that's what, and then there's everything in between. Hey, compadre, what's going on? Glad to have you here, man. So guys, one of the big reasons that this has been such a thing, okay, especially for my above the knee amputees, is that many times people will be denied a certain prosthetic device because they don't meet a certain K level. And the biggest example that I hear about from my patients and from my viewers alike is the K3 level, okay? So with the K3 level, a person is considered to be a community ambulator. A person is considered to be able to vary their cadence, meaning that they can walk at different speeds comfortably. These are the folks that are candidates for microprocessor knees, right? So it's a very coveted level in the K-level system. Hey, Chuck, what's going on? Oh, my pleasure. Thanks for being here this evening. Hey, Harsh, there you are. All right, good. It's a party now. We got Susan Walker skipped over to Facebook. I like it better. Okay, no, that's good to know, Susan. I thank you for trying out for the YouTube place. All right, so guys, the K levels are good and bad. Okay, they're good in the sense that they kind of start to let us know where we should start looking for prosthetic devices, right? One prosthetic device is not meant for every individual. There's not one prosthetic device that works for everyone. And another part of it is that not everyone is a good candidate for what I call the higher level technology, the microprocessor technology, right? Some people with their mobility will do better with a mechanical knee. Okay, or will do better with a foot that has more stability and maybe a little bit less mobility, right? So the problem with these K levels is they're still very broad, right? Has anybody been noticing this? Those of you guys who are familiar with the K levels and what K levels you are, have you guys, run into some of these problems with your K levels in getting your devices approved? Go ahead and throw that into the comments section. Hey, Linda from New York, thanks for joining us. Right? So what I especially find a lot is my K2 folks, right? I have a lot of K2 folks that are very high functioning and they're right on the border of that K3. And the irony is, right, is that my K2 above the knee amputee might be using a mechanical knee as a K2, but if they were given a microprocessor knee, they'd be a K3. So it's the chicken and the egg scenario. It's talking to the insurance company saying, yes, my patient's not a K3, but if you gave them a microprocessor knee, they'd be functioning as a K3. And it's round and round and round and round and round. It's a system that needs to be updated for sure. And this is something that as clinicians, we're all trying to figure out how to make it work for our patients. And keeping in mind, guys, it's not our goal to trick the insurance companies. And I'm going to talk a little bit about how I work with prosthetists in my area to help them with the established K levels for their patients. The goal is not to trick the insurance company. We don't want to do that. That's called fraud. That's bad. The goal is to try to really determine what is the true K level of the individual. And if the individual has the potential to progress to another K level, and we're seeing that in our treatments with our patients, how can we accurately document that as clinicians? Okay. And the reason I'm talking to this to you guys is because this is something that you can bring to your clinicians as well. Okay. There's things that as clinicians, everyone is still learning about it, trying to figure out how it works. And this is something that you can bring to your clinician. All right, hang on, let me read some of these comments. We got some good stuff. Stephen says, I got a new prosthetist, keep you updated. Thank you, Stephen. Joe says, I would think I was recently given a K3, so just so my prosthetist could bill for super expensive equipment. The doctor writing the script was the one who referred me to the prosthetist. And yes, guys, the person who officially puts your K level down in your records is your doctor, okay? But, all respect to our doctors out there, they're not familiar with these K levels. Many of them don't even know what they stand for. And that's why they rely upon the prosthetist recommendations and the physical therapist recommendations to help establish a K level to put in the records, right? Hey, Justine, she says, going from a K2 to a K3. Yeah. Daniel says, I have run into getting stuff replaced because you can't really just keep going up levels once you're a 4. No, 4 is the highest level, right? Let's see. Susan says, I'm supposedly a K3 and I don't do much of anything. See? Joe says, I think they have a little system going. Pam says K3 here, but want a blade to run with the grands. And Pam, I do know there's a lot of great organizations out there. Challenge Athletes Foundation is the first one that comes to mind. 50 Legs is another one out here in Orlando that they help people with obtaining those running blades through grants. So that's something you might want to look into as well. Hey, Jim, glad you could join us, man, with the Jack Black Neat. Nice. All right, we got Doug on board with his Coke Zero. We got Matthew says it's all about the notes, need to be detailed and concise. Hey, Rhonda, glad you could join us this evening. Got a nice crew on board. So guys, let's talk a little bit about what I've seen just in my 18 plus years of being in practice. Usually what I see, and this is when I start getting phone calls, right? Usually a prosthetist will be working with the patient and they will say, you know, this patient's about a K2, this patient's about a K3, okay? And sometimes that's what's recorded in the documentation. The prosthetist will say patient is a K3 level. They'll ship that information off to the doctor. Doctor fills out his little form, his or her little form, right? And they send it off to insurance. Insurance says, okay, here you go. Here's your K3 equipment, right? And sometimes that's all that's needed. And I've heard that happen sometimes, right? But more often than not, the insurance will turn around and say, where's your proof, right? We're not going to take it on your word that the patient is a K3 level, right? You have to demonstrate to us. You have to show us some sort of proof, right? And then the kicker is they really don't give us a whole lot of guidelines with that, right? Over the past 3 decades, we've kind of had to come up with things. So here's where we enter functional testing. Okay, and we talked a little bit about that last week, and I kind of wanted to bring it more into the light this week because I think it's something you need to hear more than once to kind of get that concept, right? So as physical therapy, you know, when you go to the doctor, right, he can order a CBC. He can order a urinalysis. He can order a fecal occult test, right? Doctors have all these tests to assess how your physiology and how the chemistry in your body is doing, right? So for physical therapists, we don't order blood draws or anything like that, but we order functional tests. And more importantly, we perform these functional tests, right? So what do these functional tests do? Okay. They can be functional tests about endurance, about balance, about coordination, about ambulation capability, about cadence, meaning how fast or how slow you walk. We have so many functional tests. Remember just even in PT school when we were training on all of these tests and which tests were appropriate for which patient population, when did you use it and how did you document and how did you perform, right? And with these tests, man, I tell you what, PTs, we are OCD people. Let me tell you, right? These functional tests have to be done precisely. If it tells you mark off 12 feet for your patient to walk 12 feet, I have my little measurement device there to measure exactly 12 feet. Don't go 12 feet and 1 inch. You got to measure for 12 feet, right? And the reason why these functional tests have to be so precise is because we want to show accuracy of results, okay? Because with these functional tests, we have normal values, right? So again, going back to the doctor analogy, when you go to your doctor, right, and he orders a blood draw, he or she is going to look at your blood and say, okay, white blood cells, that's out of the normal range. Red blood cells, out of the normal range. Oop, this person looks a little anemic. Everything is looking down, right? So same thing with functional tests. We'll look at the score on a test and we'll compare it to normative scores, right? So why do PTs use these functional tests? Well, years ago, insurance, especially Medicare, started putting a noose on physical therapy and on rehab. So we had to figure out how we could justify our treatments. We had to show insurance companies why our treatments were medically necessary. So that's why we created these functional tests. We can do some of these functional tests at the very beginning before we begin treatment, and then periodically throughout a patient's treatment to show and demonstrate progress. Now, in some cases, these functional tests can also show that the patient is not making progress. And that gives us as PTs a lot of information too. It tells us, you know what, maybe we need to change up the gears a little bit, or maybe something else is going on with this patient. We need to send them back to the doctor to get reevaluated. Okay, so these functional tests can give us a lot of information, especially when they're done properly. I have a few comments coming. Let me just see what they are. Hey, Jamar, what's going on, man? Andrea, ooh, there's my occupational therapy. I know she's going to be backing me up with these functional tests, Andrea. Yeah, that's right. You need to back me up right now. All right. Justine says, Ant Pro test also isn't that great. We're going to get to that, Justine. It's hard because people are right on the cusp, could go either way. And I've noticed it's hard to go from a K1 and work your way up because the MD was unsure what the patient could handle, not walked in 3 years. Lo and behold, she exceeded expectations and has been fighting with insurance for a higher level. Lots of letters of medical necessity and face-to-face visits with the MD. Yes. Andrea says, you got my bow right, Andrea. Good, good. Who sets what each K level entails? Good question, Susan. Medicare did years ago. And the bare, and again, we could go into details, but the bare bones of it is a K0, right, is the person who is not going to be ambulatory, who is not capable of using a prosthesis, either because their medical status is not available. So this person would not be using a prosthesis. It would not enhance their quality of life to be able to use a prosthesis, and either because they will do better with wheelchair mobility. So usually my K0 levels are folks who are very, very elderly and frail, people who are not capable, right? K1, you've got a little bit more mobility there. So it might be a very simple leg and a very simple foot, something like a satch foot. And K1 is a lot for folks who can get from, I call it point A to point B in their home. So they'll use the leg to help with transfers, meaning they can stand and use the leg to pivot and transfer from their bed to their wheelchair, from their wheelchair to the commode, to the dining room table. Okay, very, very simple mobility, and maybe just take a few steps here and there within their home. Okay, K2, getting a little bit more mobile there, right? That they're able to walk at a fixed cadence, right? So, and this is the analogy I like to use, and I can't remember, I heard this years ago from a PT, and I'm like, that's a great way to describe it. Imagine that you are crossing the street at a crosswalk, right? And the light starts blinking, telling you you've got 10 seconds left to cross that street before you become a ketchup splot in the street, right? So the K2 ambulator is going to be walking at the same cadence, and they are not going to be able to speed up their cadence, right? That's the biggest difference between the K2 and the K3. The K3 person is going to see that red light blinking and is going to start picking up the pace and getting to the other side of that crosswalk. Okay, so that's the big defining feature between K2 and K3. Once again, to me, I think it's just a little bit broad. And again, there are some folks that I've seen that they're right at the cusp of that K2 level, that if you gave them that microprocessor knee, they would take off. Now, here's the other thing, and I do want to say this, guys, that for me, it's a back and forth kind of thing. There are some K2 people that even if you were to give them a microprocessor knee, it would not necessarily improve their gait speed and quality. Okay. And this is something because I do have some patients that are sometimes, they're heartbroken because they don't qualify as a K3. They don't qualify for that microprocessor knee. And I have to talk to them and say, at this point in time in your life, the mechanical knee, and let me tell you guys, there's some really fantastic mechanical knees out there on the market. Really good ones, really good ones. At this time, a microprocessor knee is not going to necessarily help you walk better, right? So again, it's an ongoing conversation to have with your prosthetist and your physical therapist, okay? So let's talk a little bit about these functional tests. Number one, who should be performing these functional tests? I want my smarty pants answering right there in the comment section. Who should be performing the functional tests? Those of you who were here with me last week should be able to answer this right away. I want to see that in the comments section. Hey, David, you're not too late, man. You're just in time. All right. Let me make sure I got all of this. Yes, Pam, you are absolutely correct. I should see that comment section flooding, guys. Come on now. Show me some love here. PT. Thank you, Sandra. Thank you, Ben Gregory. All right. Susan, thank you, Susan. All right, there we go. There we go. So yes, guys, it is the physical therapist, okay? Or the occupational therapist. I don't want to leave out my OTs there. Andrea says, when you're on the cusp between levels, documentation really needs to support the potential for improved function. I think K3 helps with fall prevention, at least in theory. Thank you for pointing that out, Andrea. And there's a couple of other tricks that I'm going to get put out there. Thank you, Justine. The PTs and the PTAs. We got Devin saying PTs and prosthetists. Almost. Guys, I love my prosthetist. I really do. I have the highest respect for my prosthetist. But the person who should be performing the functional test is the physical therapist. Okay. Are there some prosthetists out there that they do the functional tests and they do a good job? Yes, because they went to go and receive extra training for it, right? At first glance, guys, when you look at some of these functional tests, you're like, oh, this is really not a big deal. We just follow the directions and we do it. No. Okay, there is a very specific way of doing some of these functional tests. There's a very specific way on how to interpret the data and how to document, okay? If it's not done correctly, you're not doing your patient a service, okay? And this is a conversation I have a lot with the prosthetists in my community that come and approach me and ask me, hey, how can we help this patient, okay? Now, like I said, are there some prosthetists out there that have taken the specialized training to know how to administer these tests? Yes, yes. Okay. And guys, I've gotten many phone calls from prosthetists and prosthetists who obviously care so, and they're good prosthetists, care so much about their patients. And they say, I gave my patient this test. They missed that coveted K3 level by 1 point. I don't know what to do. I know that they are potentially a K3 ambulator. Okay. I love getting these phone calls because this is where we can really work together as a team. So the most popular functional test out there for amputees right now is called the AMP Pro. And there's another version of it called the AMP No Pro for the person who has not received their prosthesis yet. No prosthesis, no pro, okay? And it is a pretty extensive test, and it has a lot of different activities that a person has to perform that looks at their functional mobility, how they get up from a chair, how they negotiate an obstacle, how they do walking on a certain distance, right? There's a lot of stuff that's examined, how, and the AMP Pro was developed by Bob Gailey, an incredible physical therapist in the field, probably one of the top physical therapist amputee specialists in the field right now. And he's done so much for our profession. And it's been used a lot, okay, a lot. Now, what I like to do is I like to take the AMP Pro and I like to combine it with other functional tests. Okay, because as Justine and Andrea, my two clinicians there, pointed out, okay, sometimes your patient might miss that K3 level by 1 point, but from seeing them, that they are in fact a K3, that they are functioning at a K3 level, that they would have the potential to be a K3 if they had that microprocessor knee or that, hydraulic microprocessor ankle, whatever it is that they're trying to get, okay? So these other functional tests that I like to use, okay, they examine things a little bit more closely. So AMP Pro does a really great job of giving you an umbrella, a nice big snapshot of the individual, okay? Other tests that I like to use, for example, the 4-square step test, right? It's a great test for balance, right? The other one is the 2-minute walk test. It's a test that we use a lot for our cardiac patients, but it can be used for our amputee patients. It demonstrates the endurance potential of the person. The 10-meter walk test, and I know I'm kind of throwing out some strange names out here to you, but I know my clinicians are going, yep, I know that one, I know that one, I know that one, right? The 10-meter walk test, that's a really great one because that one specifically tests the cadence. Okay. And I love using that test because if I have a person who missed that K3 level by 1 point, I'll pull out that 10-meter walk test and have the person do it. And if they can pass that test, that's what I present to the insurance company. And there's also another one called the Houghton Scale. And guys, I'll post all the names of these tests after I'm done on this particular thread so that you guys can just kind of, take a look at these names. The Houghton test, it tests how much you like your socket. What is your comfort level in your socket? Which is another, it's great information for the prosthetist and the PT alike. Okay. So guys, when you put all of these functional tests together, that gives you a better picture. So if you don't score as high on one test, but you score high on the other test, that's what you can present to the insurance company. And then like Andrea, my OT, just said, documenting what you see in your patient, right? When they're in treatment with you, what is their potential? Yeah? Okay. Susan says, storm here, so internet, no worries, man. We're still going to be here, Susan. All right. Hey, Patrick, there's my other physical therapist. Cindy, okay, sounds good. All right, guys, so I know I did a lot on functional tests, but I had a couple of questions come in this week about that, so I kind of wanted to address that. I did have one viewer that she tried kind of doing the functional test herself, and then she was disappointed because she didn't score very high. And again, that's why I wanted to kind of cover this tonight. The person who should be administering these functional tests are your physical therapists, guys. Okay. They're the ones who have been officially trained on how to administer these tests, and more importantly, how to interpret the data. To me, what I do like about the functional test is it tells me a lot about the patient, and they might tell me about a couple of things that I'm like, ooh, that's an area we need to work on. And sometimes, right, and I tell this to my PT students, sometimes your functional tests can help you plan your plan of care for your patient. It can identify for you the areas of weakness that you need to work on with your patient, and to work on it so that you can maybe administer that test a little bit later on again and help with their scores, right? Marianne says, Aunt Pro asked about good leg and amputated side. Do bilaterals have a good leg? Great question, Marianne. And yes, the answer is yes. All of my bilaterals that I've ever had, whether they are bilateral above the knee, bilateral below the knee, or mixed above and below, they always have a stronger side. Everybody tells me, oh yeah, my left side's a little bit stronger. Nope, my right side's a little bit stronger. Usually it's the side that has the longer residual limb. So even in my above the knee amputees bilaterals, there's going to be one limb that's a little bit longer, and that typically is the stronger one. And that's what I'll document, Marianne, on these functional tests. Now, these functional tests, the majority of them are geared for unilateral amputees. So when it comes to the bilateral, when I'm testing a bilateral, I've actually got 2 bilaterals I'm testing in the next couple of weeks. You have to just document very carefully and just, again, explain everything. Okay. All right. This question, here's another question. We talked a lot about functional tests tonight. All right. So here's another question. Is it possible to get a copy of your notes and records from your prosthetic person? And if so, how can I go about that? Yeah, they're your records. The medical records are yours, guys. The same way you can request records from your doctor's office, you can certainly request medical records from a prosthetist or a physical therapist. There is no reason why you should not have access to your medical records. I would actually kind of be a little concerned if your clinic tells you that, no, you cannot have your records, or at least a copy of your records. All right. Next question. Here's a good one. Okay, so here's one from Kathy, and this is for my folks who have to have joint replacements, right? We do have a lot of folks who end up having to have either knee or hip replacements, either on their residual limb side or on their sound side. Let's see, Andrea says, before we keep going, hey, Keith, glad you could join us. As an OT, I will check out the AMP No Pro results to see where the rough spots are. It affects dressing and toileting. See, there's my activities of daily living expert right there with my occupational therapist. So it helps us kind of pinpoint, okay, this is where this person needs to work. And not only is it going to help their scores go up, but oh yeah, they'll be able to function better in life. That's a great, so it can work that way too. All right. So this next question came from Kathy, and Kathy asks, I am a longtime right above the knee amputee, and I will be having knee replacement surgery, obviously on the sound side. I'm concerned about edema, swelling in my residual limb, and that it could possibly make it difficult for me to put on my prosthesis. That was a case when I had surgery, and it was awful because I gained 11 pounds in 7 days because of the amount of fluids I was given, right? I asked my PT, and he said I have edema in the leg with the surgery, but not in my residual limb. However, I've talked to other amputees, and they said otherwise. What do you think? And I go, okay. So guys, when it comes to your prosthetic with your residual limb, right? Many of you, the majority of you probably notice that on a day-to-day basis, your limb expands a little bit, shrinks other days, expands a little bit, shrinks other days, right? For some of you, it's just maybe a 1 sock difference. So really, maybe just a little bit snug when you put your prosthesis on in the morning, and by the time you finish breakfast, your prosthesis is fine. For other folks, right, it's a big change. Like some of you might have to go through and adjust as much as 8 ply a day or 15 ply. I know one guy, he starts in the morning with no ply socks, and by the end of the day, he's in 15 ply, and then he starts all over again in the morning, right? Everyone's a little bit different. So when you have an event happen, whether it's because you are hospitalized, whether it's because you have surgery, that's going to throw things into flux even more. So in the case of this individual, even though her surgery, her knee replacement is on her sound side, yeah, there is a big possibility that she's going to see some swelling on the above the knee side, right? Your body's all connected, folks, right? So even in my patients who have two anatomical legs, if they have a knee replacement on one side, they might have just a teensy weensy amount of swelling on the other side, but most of the time we don't notice it because they're not having to think about putting a prosthesis on in the morning, right? And yes, when you go into surgery, when you go into the hospital, they pump you full of fluids. They have to pump you full of fluids to make sure that your body doesn't crash during surgery, right? Don't want to die of dehydrations, right? No, no bueno, no bueno. So, that is something to take into consideration if you're going into surgery. That for the first couple of days after surgery, or maybe even a couple of weeks, as your body is trying to process all this extra fluid, you may not be able to use your prosthesis, and you may have to make plans to use a wheelchair temporarily while that swelling goes down. Okay. And this individual also went on to tell me that she was given diuretics, right? The first time she had that surgery, she was given diuretics to help get rid of all that fluid. And if that's the case, you also have to be very careful, making sure that you're receiving the right electrolytes to go with it. Okay. Make sense? All right. Let's go to this next question. This question. Okay. What is my experience with patients with adjustable sockets? Dude, I don't know what's in the water lately, but I've been getting at least 2 questions a week for the past 3 months about adjustable socket technology. And that's cool. Hey, roll tide, Stephen. All right. So with adjustable socket technology, I'm thinking I need to do a show on adjustable socket technology. I think that in 2022, I think I need to schedule some adjustable socket technology shows. What do you guys think? Let me hear it in the comments section. What do you guys think? Do you guys want me to do a show on adjustable socket technology next year? Hey, Bobby. Bobby says, when I've had my surgery on my meat foot, they made me wear a shrinker during surgery and until I've been able to put the leg on. You bring up an excellent point, Bobby, and I kind of do want to address that. So here's the thing, guys. Here's the thing. When you're going into surgery, right, and they're pumping you full of fluid, okay, and they have you put a shrinker on your residual limb, okay, that's a good thing because, yes, it can help pump the fluid out of that residual limb. Here's where you need to be careful. And this is something that I'm so glad I had some of the PTs guiding me in my early years as a licensed therapist, because they were the ones who taught me how to work with really, really sick patients, okay? If you are someone who has kidney issues, if you are someone who has cardiac heart issues, you need to be careful, okay? And here's why. When a person gets overloaded with fluid, either because they had surgery and they had a lot of fluids, IV fluids pumped into them, and if they have any kind of heart problems, right? And you take all that fluid from their legs and you compress it, that fluid has to go somewhere. So if the person has kidney problems, meaning they have problems filtering, right, all that fluid, if they have heart problems, we could be pushing that fluid up and causing more stress on the kidneys and the heart. So that's my little asterisk at the end of a sentence, especially to my PT students out there who are listening. If you have a patient who's got a lot of fluid, a lot of edema overload, right, you have to be very careful with your compression protocols. Okay. And this is something that, again, this is more for my PT students who are new and kind of learning how to work with patients, right? So making sure that, and also for you all, if you know that you have cardiac problems, if you know that you have kidney problems, just, have that conversation with your doctor. How aggressive can you be with that compression therapy to get rid of that fluid after surgery? Okay. And there is a way to help manage that in a safe way. Okay. Let's see. All right, so it looks like adjustable socket technology is a go. Andrea says yes. Justine says yes. Pam says woohoo. Or let's see. Oh boy. Jim says yes. Jeff says he's on his 3rd pair of adjustable sockets and he loves them. Daniel says he uses a shrinker every night, even after 5 years, and to include Martin Bionics. All right. Let's see. What else we got? Adjustable socket. Okay. Hey, Liz, glad to have you from California. Awesome. All right. So guys, looks like I will have to do some digging and see what I can do about adjustable socket technology for next year. In the meantime, Here's my umbrella recommendation for adjustable socket technology. We have a lot more options than we had even just 3 years ago when I started this show, guys. 3 years ago when I started this show, we had companies, doing adjustable socket technology. We just didn't know as much about them. And they're good companies, man. We got some good companies out there. We've got Martin Bionics. We've got Click Medical, who makes the Revo Fit socket. We have options nowadays, folks. Here's what I recommend, okay? Talk to your prosthetist, right? If you are lucky enough to have a physical therapist who's also an amputee specialist and knows about adjustable socket technology, talk to them about your individual case to see if you are a candidate for the adjustable socket, okay? Next, you need to make sure that your prosthetist has had the specialty training. Look at my face right now. You need to make sure your prosthetist has had the specialty training. We have amazing prosthetists out there. I have one of my favorite prosthetists here, right? But he himself says, I have not had specialized training in adjustable socket technology, so I will refer out for that. Okay, that's the responsible thing to do. Okay, there is specialized training. Martin Bionics has their own special clinics. Revo Fit also. They have specialized training for prosthetists to learn how to do this. The number one reason I hear when someone is not satisfied with their adjustable socket, it's because the prosthetist didn't have that training. Capiche? All right. That's all I'm going to say about that for now. All right. Kathy says, I'm planning on wearing a shrinker when I have knee replacement surgery, but I wondered if I should instead wrap the area with an ACE wrap, which I think compresses my leg better. Kathy, both of those are good options. If you are using an ACE wrap, Kathy, it has to be wrapped in a very particular way. It's a special figure 8 crisscross pattern, okay? Otherwise, you'll be creating a tourniquet effect that can actually do a lot of damage, okay? So if you are planning on using an ACE wrap, Kathy, make sure that either the clinician who's wrapping your leg or someone teaches you how to do it. I've taught many patients how to do that kind of a wrap. They do the specialized figure 8 wrap for an amputee. It's a very specific wrapping technique, okay? Denise says, yes, on the adjustable socket. Justine's geeking out. I love that about the adjustable socket segment. We're going to have to make that happen, guys. Let's see. Jim says, how about some discussion on type of liners and attachment can't speak this evening. Attachment options. Yes, Jim, it's been a while. I've done shows on liners, but it's been a while. I need to rustle up a company to get in here and help me talk about liners, man. We need to make that happen. Different ways you can wear the same socket. Some people like the ACE wrap. And guys, I did a little segment this past week, a couple of days ago on shrinkers, because one person was asking, how long they should be wearing their shrinker, right? And how often should they use it? And I, described in the segment how some people may use the shrinker just for the first few weeks or few months after their surgery, and then their leg stabilizes and they're good to go. But a lot of people, actually, the majority of people I know of, they use the shrinker in some way or fashion for the rest of their life. Many folks, after they've established a pretty stable limb, they'll continue to use the shrinker at night for comfort. It just helps to compress that tissue, sometimes that extra soft tissue, and also because it helps control those little fluctuations in volume, right? So wearing a shrinker at night can also help when it comes to putting your leg into the socket first thing in the morning. So that's my thoughts on that. All right. Ooh, here's this one. This is the one that I was excited about because I was like, oh, a running question. So there's a really lovely group on Facebook right now. It's called Amputee Runners. And it's exactly that. It's for amputees who like to run. And I was invited to be in the group. So I have fun. I'm a runner. I love to run. I love to swim. And I love to play tennis. Those are kind of my trifecta of sports and how I like to stay in shape. So I always like going to that support group and just seeing what people are chit-chatting about. So one young lady said, since I tore my hamstring, I've been itching to run again. However, the doctor said I can't do that until I'm 100% pain-free for 2 weeks at least. So aqua jogging it is. I've never tried this, and I'm determined to keep up with my triathlon training and not start at square one. Okay. So yes, Daniel, an amputee running group. Okay. So with the amputee, with an amputee runner, guys, it's a very specific candidate. And in my clinic, I've had several folks come into my clinic that I've taught them how to run. Okay. And like I said, I'm a runner myself. When it comes to injuries, and not just with running, with any sports, I get really, really picky. That's the OCD PT in me that comes out. Okay. And I say to my patients, or I say even to myself when I get an injury, do you want to be the 70, 80, 90-year-old who still runs 1 mile or 5K races? Okay. Do you want to be the 70 or 80-year-old who can still go out for a jog every day? Okay. And for those of us who are running nerds, the answer is like, yes, we want our running. That is our drug of choice. Right? So whenever you have an injury that comes up, treating it right away and treating it correctly, okay, is going to allow you decades from now to continue to run. Okay. And the reason why, I mean, I'm OCD with my patients, even if they're not runners, but I'm particularly OCD because of the fact that with running, you are putting a ton of stress on your body. You know, some of the research literature will tell you that you're putting 8 to 10 times your body weight force through your joints when you're running. That's a lot of stress and force on those joints, right? Okay. So if your muscles are not strong, if you are not coordinated, if you don't have good running technique, you're going to run into a lot of injuries that are going to sideline you. And here's what I see a lot. And I see this in my mom tribe who are runners at my kids' school. I see this in my younger runners. I see this in my runners. They get that nagging injury. And because they're young and because they're in good shape, they can kind of run through it and they ignore it, right? Or they'll rest for maybe a week or two. And then when the pain goes away, they start running again at the same intensity that they were before. And then what happens? That nagging injury comes back and it comes back worse. Okay. So when I was speaking to this particular young lady on this thread, I said to her, your doctor's right. Okay. When it comes to running, you want to be pain-free. Okay. And whether it's 1 week or 2 weeks is different for every individual, depending on the severity of the injury. You want to be pain-free. Okay. If you're going to be putting that amount of stress on your body, yeah, everything needs to be working, especially if you're an amputee. Okay. Because if you injure that one sound leg, you're out of business, right? You got to take extra care of that, right? And, this young lady went on to say, and it was a very nice conversation. This young lady went on to say, well, I hate to say it, but I really don't have time for PT. And I go, here's the thing, because I've been guilty of this myself, right? Whenever you don't have time for PT, it's eventually going to come back and bite you in the rear, okay? Because you might rest for a week, maybe even 2 weeks. You're going to get back to running. You're going to injure yourself worse. And then you really got to do the physical therapy, okay? So here's my option, because I get it. I'm a mom of 4 kids. I've got 2 businesses I'm running. I really don't have time to go 3 times a week to a physical therapy clinic to get treatment every time I get, some sort of overuse injury. And I've had my fair share of overuse injuries. But typically, guys, and this is mainly for my runners, okay? With my runners who have injuries and they have this crazy busy schedule, if I don't have to do anything manually on them, like I'm not having to do any soft tissue mobilization, if I'm not having to manipulate anything with my hands, if it's basically guiding the person through an exercise protocol to strengthen the parts that are weak and to make sure that they don't get injured again, I can work with my patients and say, okay, maybe you don't need to come see me 3 times a week. Let me see you once a week. I'll give you that workout schedule because I know that they're used to doing a lot of these exercises, right? And let them do it that way. There's also telehealth options, guys. Okay. So for my runners out there, okay, really encourage you, because for me, guys, I love to run. And when somebody tells me I have a physical therapist that kicks my butt on a regular basis when I'm not behaving. And whenever she tells me you got to stop running, I'm like, no. But I know that if I don't do what she tells me to do, I'm going to be out even longer. Okay. And then when it comes to returning to running, guys, there's, depending on the severity of the injury, there's a gradual way. It's not, okay, strengthen your body, do the rehab, and then boom, start running again. No, you need to gradually ease yourself into it. Okay. With my patients, sometimes I'll do slow jogging out in front of my clinic, and we'll go for an outdoor intermittent run where we do run walk at different intervals to get their body used to it. With some people, I'll put them on a treadmill so I can make sure they're not going to overdo it, and I'll control how fast they're allowed to go on the treadmill. Okay. But again, this is my personal love as well as my professional love. So it's to say, if you want to be that 70, 80, 90-year-old who's out there still jogging every day and running races, you got to take care of your body now. Okay. That's my soapbox. Let's see. Andrea says, I think people get railroaded into a certain suspension system. Yep. And if they don't know what all the options are, just saying. I agree, Andrea. And I think a lot of people, when it comes to suspension systems, especially the one with elevated vacuum, that really brings a lot of fireworks out for people. I think people get caught up a lot on the technology and the fancy technology. I think when it comes to suspension, it's like everything else. You need to start with the more simple suspension and then kind of work your way from there. And talk to your prosthetist about the pros and cons of the different types of suspension, just to see what is appropriate for your lifestyle and even for the changes in your lifestyle. So for example, my runner girl, she's a below the knee amputee, and she only uses a sleeve for suspension for her walking, right? But for running, she needs a little bit of extra. So she'll use a pin lock suspension for running, just to get that extra suspension in there. Daniel, you can look up the running group. I think it's literally amputee runners. Go ahead and look it up, and then you fill out a form to apply for the group. Bobby says, I just need to learn to walk. Yes, learn to walk first, folks. Hey, Phil, glad you could make it. Bobby says the best technology isn't always the better choice. And I don't like to say the word best technology. I just like to say, the fancier technology, the technology that has a little bit more bells and whistles. And again, I love all this new technology that's coming out. I see it doing amazing things, but it's not a one fit for every single individual, right? Let's see. Keith asks, I'm only 3 months on a prosthesis after a right above the knee amputation, and I'm able to walk okay with the cane on my left side, even if it barely touches the ground. Very good. As soon as I lose the cane, I have a hitch on my amputated side. I'm working on this, but was wondering if this is normal and any suggestions for working out the hitch. I'm using a shuttle lock liner since my leg is changing. Very active and doing lots of activities and walking, just none of them properly. So Keith, bravo to you, man. 3 months after a right above the knee, that's very good. So Keith, a couple of things. And this is, again, if you're working with a physical therapist, have them really take a good look at you so that they can pinpoint where this little hitch is coming from. And Keith, actually, now that I think about it, and yes, I'm shamelessly plugging my own YouTube channel right now. If you go to my YouTube channel under Cosi Talks, hit subscribe. And then in the live event videos, okay, I did one full show on gait deviations, meaning different ways of walking or hitches, right? And I talk about the different kinds of gait deviations out there, what causes it, and how you can work on it. So Keith, that might be a good one for you to watch a little bit later on. But in the meantime, Keith, you need to find out what is causing that hitch. Is it because you still have a little bit of weakness in your glutes? That's usually one of the big ones. Is it because maybe your prosthesis needs a little bit of alignment tweaking, right? The more active you become, right, your residual limb will change. It might shrink a little bit, and you might sink down a little bit more into your prosthesis. Or it could be that certain alignment that your prosthetist made before you were walking a lot isn't appropriate for you now, and you need to go back to your prosthetist to get some of that alignment tweaked and changed, right? So that's another thing. The other thing is higher level balance, okay? For my patients, when they are towards the tail end of their treatment, my focus is more on balance. So I work on strength and range of motion and balance all throughout the treatment. But in the beginning of the treatments, my focus is more aggressive with the muscle strengthening and getting that power and a little bit of balance work. And then as the individual progresses, my focus becomes more on balance. And when I mean balance, I mean I put my patients through the gauntlet. I have them going over hurdles. I have them jumping over cups. I have them going up and down steps and ramps and uneven terrain like grass. all over the place, okay? Because sometimes, Keith, it's just about your brain relearning that balance skill to have the confidence to prevent that little hitch from happening, okay? So there's a lot of things that can contribute to having a little bit of a hitch when you let go of that cane. It's pinpointing it and then really working on it, Keith. And again, I'm hoping that you have a good physical therapist who can just give you a good evaluation head to toe and really pinpoint that for you. But strong work, man, strong work. Okay, so David says, by adjustable sockets, are we talking about BOAs in a hard socket or soft socket? So it's all over the place, David. I've seen some adjustable sockets that prosthetists will kind of, like one of the old school prosthetists, oh, and I miss him so much. He retired, Waldo. He was an amazing prosthetist. He kind of created his own adjustable socket before it really started becoming a thing, where he would just window a panel, and then he had the cords and he would put a BOA on there, a BOA dial, and that's how he would do an adjustable socket. And then you had something like the limb innovation socket, where they had the 4 struts coming up, and then they would adjust it with the BOA dial there. I know the RevoFit uses a BOA dial. Martin Bionics adjustable socket, heard good things. I'm not as familiar with that particular socket. So each company has their way of doing the adjustable socket technology, David. Justine says, I feel like the majority of my patients come in with the same liner, same socket designs, no matter the age, prior mobility, and current mobility. And you know, sometimes, yeah, folks, you sometimes, you know, same way you run into physical therapists who are hard set in their ways sometimes as well. You might find some prosthetists that they like a very particular foot, particular knee, particular socket, particular liner, and it's kind of tough to break them out of that mold. And this is where, as a patient, you can advocate for yourself and just, you know, have the conversations you should be having with your prosthetist and your physical therapist, okay? When it comes to choosing your prosthetic technology, is to tell them, what are your goals in life? You know, what is it that you want to be able to do with this prosthesis? Do you have particular hobbies? Does your job have certain requirements that you need your prosthetic leg to be specially designed to do? Okay. And, you know, when it comes to the different companies, guys, you know, one of the things I love about my show is I've had a chance to get to know several different companies, either because they've come on the show as sponsors or because I've talked to them and reached out to them in other avenues. But learning what your options are, you know, asking your prosthetist to have a couple of sales reps come in and talk to you about a couple of different options for feet. And many of these companies will have trial programs. First one that comes to mind is College Park, right? So if you find that your prosthetist is a little reluctant about trying something different than what they normally use, squeak the wheel a little bit. Squeak that wheel. You have that right as a patient. And, you know, if push comes to shove and your prosthetist doesn't want to discuss different options with you, and they're telling you, nope, you only get this one foot, this is the foot you need because that's what I'm telling you you need, you might want to find a new prosthetist. And I'm just as tough on my PT, OT colleagues as well, you know. The clinician is here to serve you. That's our whole point of being here. So if the clinician's not serving you, you need to find a new clinician. All right, moving on. Ernesto, hey, greetings, man. Thanks for coming on board. So Cosi talks and tortures. Yes, that's why I get paid the big bucks. I'm kidding. Trust, trust, trust. Yes, Jim, that's absolutely correct. Keith, he's referring to you when it comes to that leg, especially when you are working hard and your strength is getting better and everything is getting better. It's learning how to trust that prosthetic leg. And then again, these balance exercises that Bobby says I like to torture my patients with, those balance exercises are fantastic at helping you build that trust in your prosthesis. All right, Keith, good. And Keith, update. I like to hear updates from people. What is the difference between a PT and an OT? Ooh, Andrea, please tell me you're still on board. Good question, Bobby. So PT, physical therapist, OT, occupational therapist, all right? PTs are involved with the rehabilitation and assessment of gross motor function. So that's a big old fancy word for just saying we assess the human body from head to toe, okay, in terms of how it moves in certain movements in life. The biggest one being gait, walking, how we move from one place to the other. When it comes to occupational therapy, right, they assess the human body as to how it regards fine motor function. So fine motor, okay, meaning buttons, activities of daily living, how you use your body to perform your activities of daily living, whether it's involved with dressing, toileting, self-hygiene, right? That's the big general thing. Now, PT and OT are like peanut butter and jelly. Most of the time you will see us together working as a team, especially in the rehab hospitals. I know some of the best moments I had working at Jackson was working with some of my favorite OTs, especially in the spinal cord injury unit. Just great times working with these great individuals, okay? So you see them everywhere, all over the place. We're everywhere. All right, let me see. Okay, Jeffrey, I am so sorry it took so long to get to your question, but I am here with your question. Jeffrey asks, about hydration, I am just not drinking enough water. Every time I do a big long walk, my mouth is super dry. I drink a lot after that walk, wondering with the amount of energy I'm using, how much should I be drinking before I start my walking and exercise? Thanks. I love that I'm getting so many like athlete related questions tonight. So Jeffrey, I'm reading Jim's response. Jim, I love that. Andrea, I really hope you're still on board. PT helps you get to the kitchen sink. OT helps you wash the dishes. That is hilarious. And that's actually a really great analogy. Pam, not entirely true. Pam says PT is below the waist, OT is above the waist. And this is a very common misconception. A lot of people say PT only works with legs, OT works with arms. No. As physical therapists, we have extensive training on the assessment of the cervical spine, shoulder, elbows, and hands, okay? You will find physical therapists who are hand specialists. You will also find occupational therapists who are hand specialists. There is some overlap there, okay? But a physical therapy will treat you for a rotator cuff tear, right? So the reason why a lot of people get that confused is when you do fine motor skills and fine motor function, you're using your hands, right? Buttons, brushing your teeth, doing those dishes that Jim says he's going to do, right? And when you're doing gross motor function like walking, well, primarily you're using your legs. So that's where that misunderstanding comes into play. But no, as physical therapists, we do head to toe treatments. Yep. And occupational therapist does the head to toe treatment because let's face it, in order to get to, using the toileting and using your hygiene and everything like that, you're using your entire body, not just your hands. Hope that made sense. Keith says my wife was an OT. So Keith, you should know this. All right, guys. So let's get back to the question on hydration. Okay. So hydration, super, super, super important. And it's interesting. When I've had Greg Menino, one of my favorite prosthetists on this show as a co-host, he's an amputee himself and a big time athlete. He says that he really monitors his hydration because sometimes when he gets dehydrated, it could potentially kick off his phantom limb pain. So this is something for you to listen to, even if you're not necessarily a high-end athlete, right? And Jeffrey is tearing it up, man. He's a bilateral above the knee amputee, and he is just everywhere, doing exercise, doing all the housework, mowing the lawn. He's incredible. So Jeffrey, the first thing I would do is weigh yourself before you go walking and then after you go walking, okay? And this is something that runners will also do, because we sweat out a ton of water, especially here in Florida, sometimes as much from 3 to 5 pounds of water on a 6-mile run, okay? And you have to be able to replenish that amount of water and electrolytes into your body, or you're gonna get into some trouble, okay? So by the time you feel thirst, usually that means it's a little too late. You should have started drinking a lot sooner than that. And drinking water and staying hydrated, guys, it's not just about pounding a gallon of water after your walk. You need to have constant hydration throughout the day, okay? So if you're into a lot of exercise and you're not sure if you're getting enough water, that's usually one way to do it, is to weigh yourself before you go walking and then weigh yourself afterwards. And if you've lost 2 pounds of water, then you know you need to start drinking about 2 pounds of water in that day, okay? The other way, and probably the most accurate way to test your hydration, is through your urine. That's what's gonna tell you whether or not you are dehydrated. If it's a dark amber color, then start carrying that water jog and start drinking, okay? If it's a nice pale yellow, then you're good to go. If it's clear, probably means you can back off a little bit with the water, or just a little bit. And that's honestly the best way to monitor yourself. And also for many of you who are sensitive to your limbs shrinking and getting bigger, okay, that's usually an indicator to a lot of my patients as to whether they're hydrated properly or not. Good question, Jeffrey. Very good question. All right, guys, I am talked out, and that's tough because I'm Cuban and we talk, but I am talked out this evening. So guys, I'm going to go ahead and sign off for this evening. Guys, if you have the chance, please go to my Instagram and go ahead and follow me if you're not already following me. It is helping me to grow the show so that I can continue to bring specialty talks onto the show, like that adjustable socket technology talk that I need to figure out how to get on the show for next year. Hey, Lanya. Oh, I'm so glad you could join me this evening, Lanya. All right, guys. So thank you, as always, for letting me be a part of your lives this evening. I will see you next week. Same bat time, same bat channel. Start sending me those questions for next week, guys. Bye. God bless.